One day I open my email and there's an email from someone I've never heard of before. They're a doctor and they'd feared neurology their entire life. They come to one of my courses, they had a great time, they learned stuff. And the next day on ward service, they're doing gen med, internal medicine. Patient comes in diagnosed as delirious. They examine the patient and they diagnose an internuclear ophthalmoplegia, an INO. They get an urgent MRI. Patient's had a stroke and it's exactly in the medial longitudinal fasciculus. And that's amazing. And they just emailed to say, thank you. That was one of their greatest experiences they've ever had, actually being at the bedside and making a diagnosis. And that's what makes neurology so amazing. And today we're going to go over exactly that, the internuclear ophthalmoplegia and lesions in the medial longitudinal fasciculus. Lots of big words, but here we're doing the clinical neuroanatomy course where we're going from the very basics, taking things simple, building it up. Once you understand it, we're going to go around one more time and learn it all again in more detail. So let's get started. So last week we went over the brainstem and the rules of 4. And specifically, I mentioned the medial longitudinal fasciculus, the MLF, and that it runs between the 6th nerve nucleus and the 3rd nerve nucleus. And I said this week we'll go over that in more detail. So let's go over this. And I mentioned how that tract was important for us to coordinate our eyes to look left and right. So it's important for lateral gaze. So let's talk about what the pathway is for lateral gaze. So we're going to start off in our frontal lobes, actually, taking us all the way back to the start. And so in our frontal lobes, I'm going to label this left, I'm going to label this right, and this is our frontal lobe. There's a region in your frontal lobe called your gaze centers. This is where the initial trigger comes on whether you want to look left or right. Now, if you want to look right, that comes from the left frontal lobe. And if you want to look left, that comes from the right. So the pathway, and we'll do this over here, comes down to the brainstem. And so the first part of the brainstem is the midbrain, and the second part is the pons. And we don't need to go into the medulla because that's not involved. So there's 2 parts of your brainstem. There's the midbrain, and then there's your pons. And if you remember, what we're trying to do is we're trying to get the eyes to move right and left. So as an example, let's say I want to look right. So if I want to look right, then I need to get my right eye to abduct, and I need to get my left eye to adduct. Right eye abduction, lateral rectus muscle, and that's the 6th nerve. So my right eye, and again, I'll just draw a little dot down the middle here. So that's going to be coming from my 6th nerve nucleus. Let's draw that. And the other side, the adduction, is medial rectus, and that is controlled by the 3rd nerve. So left eye is 3rd nerve. So we'll draw that all the way up here, 3rd nerve. And if you remember from our rules of 4, your 3rd nerve comes out of your midbrain and your 6th nerve comes out of your pons. So to coordinate the eyes, we've got the 6th nerve in the pons and the 3rd nerve in the midbrain. So they're in 2 completely different paths. And so we need to connect the 2. And that is where the medial longitudinal fasciculus comes in. We're connecting these 2 cranial nuclei together so they can coordinate looking right. So let's track these pathways. So let's just say look right. So the signal comes from the left gaze center in the frontal lobe. That pathway comes down to the pons to begin with. And it comes to a region in the pons in the posterior aspect of the pons. And so it goes to a region called the PPRF. And that stands for the paramedian pontine reticular formation. Paramedian pontine reticular formation. As always, please excuse my horrendous drawings here. From the PPRF, the pathways then make their way to the 6th nerve. So PPRF, and then it goes to the 6th nerve. So we're going from the posterior aspect, paramedian, in the posterior aspect of the pons, and it goes to the 6th nerve. From there, the nerve fibers of the 6th nerve are triggered, and that goes out to our eye, and our eye looks right. From here, we've got 6 nerve fibers in the 6th cranial nerve, the abducens nerve, coming out from there. At the exact same time, we've got signal going up the medial longitudinal fasciculus to the 3rd nerve. And so the 6th nerve really has 2 fibers coming out of it. it has the fibers that are going to create and turn into the sixth nerve, the abducens nerve. And those fibers are going to go out to the lateral rectus and control the right eye. And there's also fibers that come out of the sixth nerve nucleus, which are the medial longitudinal fasciculus. And these decussate almost immediately and then make their way up the opposite side to the third nerve. And now the third nerve nucleus then gets activated. The third nerve nucleus then sends that signal through the third nerve, and it goes to the left eye, and it tells this eye to adduct. So it's moving in. So imagine these eyes are looking this way out into the world. Okay, this is my left, this is my right, left, right. This is the back of the brain. These are the eyes at the front. This is the left eye abducting in, and this is the right eye adducting out. And so now we've got that activation. So if we were to remember our pathways, we're going from the left frontal lobe down to the right paramedian pontine reticular formation. A lot to say. That sends fibers to the sixth nerve nucleus. The sixth nerve nucleus gets activated, sends signal down the sixth nerve to the lateral rectus muscle that abducts the right eye. At the exact same time, and incredibly quickly, the sixth nerve sends the same signal and the same innervation through the medial longitudinal fasciculus, which decussates to the opposite side, runs up the midline of the brainstem. Remember, it's one of the M structures, to the third nerve nucleus. And at the third nerve nucleus, that activates the third nerve that sends fibers to the medial rectus. The medial rectus in the left eye now adducts, and in combination, the two have now looked right. So that's the entire pathway to look right, and it's the exact opposite when we want to look left. The right frontal lobe activates, the opposite side, etc., etc. So that is the pathway of lateral gaze. That is how we look left and right, and that is how the medial longitudinal fasciculus is important. Now, what about an intranuclear ophthalmoplegia? And that is something that occurs when you get a lesion at medial longitudinal fasciculus. Okay, so now let's say I have a lesion here in the medial longitudinal fasciculus. Nothing is going to be able to get through that pathway. So let's look right one more time. So we want to look right. The signal comes from the left frontal lobe. It travels down to the paramedian pontine reticular formation. Remember that? It goes to the sixth nerve. Great. The sixth nerve sends its signal out through the sixth cranial nerve to the right eye. And the right eye will do what? It will abduct. And it will look out. And it starts sending the signal to the opposite eye. But what happens at that stage? Nothing gets through. Nothing gets through at all. Because the signal doesn't come through, if we look at the left eye just stays exactly in the middle. Doesn't move. So in an INO, one eye will abduct and the other eye won't move. And the eye that is abducting will develop some nystagmus. It's not truly nystagmus in very technical terms, but when you look at it in the bedside, it looks like nystagmus. It's beating. In a way, think of it as that eye that's moved is saying, hey, catch up. Get in here. We got to be looking to the right. But it's beating. It's kind of trying to do that. And it's really to do with the amount of innervation both eyes getting, and one's getting too much and one's not getting enough, etc. But too complicated. We won't go into that. So a lesion in the left medial longitudinal fasciculus means the left eye doesn't. So when one eye abducts and the other eye stays still, that is the side of the lesion. The eye that doesn't adduct is the side of the lesion. If I get them to look right and the left eye doesn't move, then it's a left INO, and the lesion is in the left medial longitudinal fasciculus. Easy. Now, if I was to get a lesion on the other MLF on the other side, then I would have bilateral INOs. And you see that in certain conditions like multiple sclerosis. And the reason why we see intranuclear ophthalmoplegias in patients with multiple sclerosis is because the path, the firing, the speed the nerves have to work together to coordinate the eyes in perfect harmony. You need to have highly myelinated fibers in that region to send that signal so quickly. And so for some reason, I'm sure there is a reason, I don't know it, but maybe somebody in the comments can tell me, MS has a predilection for the MLF because of the high myelination, and it strips the myelin from those regions, whereas we don't quite see it as much in other demyelinating conditions like MOG and NMO example. Now, you can get intranuclear ophthalmoplegias when you're elderly as well, and strokes can certainly do this. In that case I mentioned at the very start with the elderly patient, that was a stroke. So acute onset in an elderly patient with an intranuclear ophthalmoplegia, I want you to think about strokes. If you ever see bilateral INOs, that's almost MS until proven otherwise. It's a very high specificity for MS in those conditions. So 2 more things I want to talk about. One is a pure loss of lateral gaze, and the other is 1.5 syndrome. And so to understand that, we need to draw out the opposite side of the brainstem as well. And so here we've got the 6th and the 3rd and the MLF that connects it. Now, if I get a lesion in the PPRF, what could I potentially present with? Well, I would have no signal getting across to the 6th nerve. So let's say I want to look right. Signal comes down, goes to the PPRF. Then what happens? Goes nowhere. So doesn't go to the 6th nerve nucleus, doesn't go to the 6th nerve, doesn't abduct the eye, doesn't go up the MLF, doesn't go to the 3rd nerve, doesn't adduct the eye. And so in the process, you don't look right. So you get a loss of lateral gaze to one side. So a PPRF lesion can do that. At the same time, if I was to get a 6th nerve nucleus lesion, not a 6th nerve palsy, not fibers that are coming from the cranial nerve nuclei. And so when the fibers are still in the brainstem, we call those the fasciculus. And so not the fasciculus from the 6th nerve, but the actual nuclei. Well, what happens there? I want to look right. Path comes down, PPRF, goes from PPRF to 6th nerve. Well, nothing comes out to abduct the eye, and nothing goes through the MLF. So again, you lose right-sided gaze. You lose lateral gaze to one side. And so if you want to think about where the horizontal gaze center in the brainstem is, really it's the 6th nerve as well. So never forget that the 6th nerve nucleus lesion leads to lateral gaze loss to that side. A right-sided 6th nerve nucleus lesion, you will lose gaze to the right side. The eyes cannot move to the right at all. They can move to the left, but they can't move to the right. Okay, so that's loss of one side. But let's do one more. What if I had a really big lesion? What if I had a lesion that spanned all of this? Or maybe it was even just half of that, like there. Let's just do a lesion there. So I want to look right, and I've got a lesion that is affecting my 6th nerve nucleus on the right, as well as the right-sided medial longitudinal fasciculus. So not the left side, but the right side has also been taken out. So I want to look right, comes down to the paramedian pontine reticular formation, goes to the 6th nerve. Can I look right? Nope. Remember, 6th nerve's knocked out. The nucleus of the 6th nerve is knocked out. I can't look right. Now I want to look left. Let's do pink. So I want to look left. That comes from my right frontal lobe, travels all the way down to the left-sided PPRF. That takes us to the 6th nerve nucleus. The 6th nerve nucleus sends out fibers to the left lateral rectus, and the left lateral rectus will abduct. Fantastic. And then we will have pathway fibers going through the MLF. Oh, well, you can't. It's blocked. So we actually don't get any fibers going to the 3rd nucleus. And so what do we develop? We get an INO. So we get an INO on this side. This eye doesn't move, and this eye starts beating and saying, hey, catch up, catch up, catch up. So what do we have? We have complete loss of gaze to the right, and I've got a right-sided INO, so only my left eye moves. So that's 1 complete loss plus half, which is the INO. That's your 1.5 syndrome. And that is from a really big lesion that's taken out the side that you can't look, and you got the INO on, taken out the 6th nerve or the PPRF as well. So the gaze center, as well as the medial longitudinal fasciculus. And here's just a little bonus one. Tell me in the comments below, what's an 8.5 syndrome? So we've got a 1.5. What's an 8.5? Put that in the comments below and we'll see how many of you get that. Okay, one more final thing. So I'm at the bedside. I ask the patient to look right. Their right eye abducts, the left eye just stays exactly there. How do I know that that left eye is not moving because of a third nerve palsy or a medial rectus problem or myasthenia gravis, a neuromuscular junction problem? And the key is in accommodation. What's accommodation? Look at my pen, move your eyes in, all the way in, all the way, all the way in. And what are we doing? We're getting the eyes to converge on themselves. So we need to get the eyes to converge. And in an INO, the eyes can converge. However, if there was a medial rectus problem, the eye wouldn't converge. It would still be stuck there and the other eye would come in. But in INOs, they both converge perfectly. Why is that? And that's because when I converge medial rectus is just the third nerves. And so I am just using both third nerves. This entire pathway is not needed. And so you are not activating this lower pathway and are only activating your third nerves on either side. And that's kind of a reflex pathway that we have where we converge, we accommodate, the pupils constrict. And so if you want to confirm an INO, you've got to get them to converge and to accommodate and see that medial rectus come in. Big trick. Patient with myasthenia gravis comes in, you think it's an INO. And if you didn't do that, and if they had myasthenia and you got them to accommodate, that eye would not move in because the problem is in not the pathways, the problem is in the nerve or the nerve muscle junction. But that's it. That's as simple as it is. So nothing complicated. You just have to understand the pathways, you have to understand the tracks, and you have to understand where the lesions occur for you to get your symptoms. So now you can tackle INO at the bedside. You understand what the medial longitudinal fasciculus is. And now in the larger context of the rules of 4 and the brainstem, you'll understand it perfectly. What are we going to do next week? Next week, series of questions. We're just going to do questions, a whole bunch of cases to help us localize in the brainstem, having learnt what we have in the last episode and this episode. My name's Prashant. I'm a neurologist. I love to teach. I love it. Okay, this is where I get my joy. So subscribe so that I can teach more people. See you next week.